Hello students, we'll start with yet another topic under chemotherapy coming under antibacterial agents, antileprotic drugs. That is the chemotherapy of leprosy. So the learning objectives for today's session will include to know the various forms of leprosy. Second, to study the classification of drugs coming under this antileprotic drugs, that is leprostatic drugs and the pharmacology of these drugs. And third, to know the WHO regimens in the treatment of leprosy. Well, let's see the first learning objective about leprosy and its forms. It has been estimated that around more than 20 million people worldwide have leprosy. Now, this disease is also called as Hansen's disease. And this is widespread in Asia and in Africa, more particularly in India and China. What has been estimated some 5 years back was India alone had about 4 million leprosy patients. But due to the development of effective chemotherapy, most of the cases are managed outside the hospitals. So, what is leprosy? Leprosy, which is also called as Hansen's disease, is a chronic infectious disease which is caused by an acid-fast bacillus called as Mycobacterium leprae. It is related to the tubercle bacillus. The characteristic feature with this bacilli is that it multiplies very slowly, like tuberculous bacteria in the body, and it does not develop at all in the culture media. Because of this main reason, so vaccine cannot be produced. So there is no vaccine still available. It is basically a disease of peripheral nerves. So this mycobacterium, since it's slowly multiplying, it will slowly eat up the nerves, peripheral nerves. And this primarily affects which parts of the body? The skin, the eyes, the mucosa of the upper respiratory tract. Look at that. Muscle, bones, and testes. Basically, there are 4 forms of leprosy. They are divided depending upon the strength of the Mycobacterium tuberculosis present. The first form is the intermediate form, which shows localized hypopigmentation of the skin and sensory loss. The second is the tuberculoid form, which is also called as the possibacillary leprosy. And this shows a high degree of resistance. Now, what does this mean? This means that the body's own T cells will produce interferons. It will try to defend, the immune system will try to defend, the T cells will produce interferons, and these interferons will enable the macrophages. Remember macrophages, the defense cells, to kill the intracellular microbes. So you will have lepromin test positive in such cases. That is, the since it is killing and the microbes, the bacilli are moving out of the macrophages, the smear will be showing positive. So this is tuberculoid form. Lepromatous form, which is the second form, is also called as multibacillary leprosy. It has got a low degree of resistance, means the immune response is not that strong now at this stage as compared to tuberculoid form. And this is dominated by interleukin 4, the presence of interleukin 4, a substance which blocks the action of interferon. So therefore, even though the person is infected with the microorganism, it will show lepromin test negative because they are all dwelling within the macrophages. And the fourth form is the dimorphous type, which shows symptoms of both tuberculoid as well as lepromatous, both lepromin test positive as well as negative. So the intermediate form is the basic form it starts with. If it is not well treated, it may go on to tuberculoid form, which may go on to lepromatous form of leprosy. Okay. Well, coming to the classification and pharmacology of drugs used in the treatment of leprosy, drugs are broadly classified depending upon their structure. The first classification is sulfones. In this, the major drug is dapsone and sulfoxone sodium. Dapsone is a major drug. And the second classification is non-sulfones. Where several classes are coming under this classification, like the antibiotic rifampicin or phenazine diclofazimine or thioureas like thiocitazone or other sulfonamides or other anti-inflammatory drugs like aspirin or corticosteroids for the treatment of leprosy. So here you have, like how we have seen with the anti-tubercular drug, like INH is a main drug. Here you have dapsone as a main drug for the treatment of leprosy. Although there are some common drugs like rifampicin because it is an antibacterial drug. So rifampicin is also included and they have the same mode of action. So let's see the first drug, dapsone. Dapsone is chemically related to sulfonamides. So being chemically related to sulfonamides, so the mode of action will be similar to that of sulfonamides as well. So this is a bacteriostatic drug. So you can look at the structure of dapsone. It's having a resemblance to that of PABA as well. So its action is antagonized by PABA, and the final net effect is inhibition of folate synthesis. So inhibition of folate synthesis is the main action of dapsone, which is similar to the action of that of sulfonamides. But the problem with dapsone is that resistance is increasing. Resistance with use, the resistance also increases. Bacterial resistance also increases for this drug, and therefore the drug has to be combined with some other antileprotic drug. A combination of drugs are required. Talking about the pharmacokinetics, this drug absorbs very well, gets absorbed very well. It is widely distributed throughout the body, water in all tissues. Now, half life is 24 to 48 hours, and because of this long half life, it also has a tendency to remain in the tissues for a longer period of time. For example, it gets deposited in the RBC cells and all. So, and moreover, there is a enterohepatic recycling of the drug. Acetylation, it gets metabolized by acetylation and gets excreted in the urine. So pharmacokinetics is very simple, except that it has got a tendency. The issue with pharmacokinetics is that it has got a tendency to remain in the tissues for a longer period of time. Well, talking about the adverse drug reactions of dapsone, now this has got a very peculiar adverse effect. Some of them are very common, in fact. Let us see one by one. Adverse reactions developing to the sulfone therapy, they are all dose dependent. So, 10% of the patients who are being treated with dapsone, they will face all gastrointestinal upsets like nausea, vomiting, anorexia, and even fever or abdominal cramps and diarrhea. Other common effects like headache, excitement, nervousness, insomnia, they are also experienced by the patients. Now, some characteristic peculiar effects, like for example, hemolysis of red cells. This is very much seen in glucose 6 phosphate deficient patients. So, patients having this enzyme deficiency will be having this as an adverse effect on treatment of dapsone, hemolysis of red blood cells, because the membrane enzyme it fails to maintain the integrity of the red blood cells, and on exposure to the drug, hemolysis takes place. This results in methemoglobinemia also, a condition wherein the oxygen carrying capacity of the blood is lowered, and also a condition called as Hind's body formation. Now, Hind's body formation is a state wherein dapsone and its metabolites they get deposited inside the red blood cells, and they appear the red blood cells they cause denaturation of hemoglobin, and these hemoglobin they will appear as bulged bodies called as Hind's body within the RBC cells. So they finally decrease the functioning of the red blood cells. That is called Hind's body formation. So oxidation of the hemoglobin moieties, which results in deposition of it within the RBC cells, resulting in Hind's body formation. Other characteristic effects are hypersensitivity reactions like skin rashes or allergic dermatitis seen. Even acute psychosis is observed in patients taken with dapsone because of peripheral neuropathy, which is reversible in nature. And a very characteristic reaction with dapsone is lepra-like reactions, also called as sulfone syndrome or erythema nodosum leprosum. So these are all similar terms: lepra reactions, sulfa syndrome, and erythema nodosum leprosum, which is thought to be parallel to Jarisch eczema reaction, and this reaction is slow to occur, and within 5 to 6 weeks of initiation of therapy only, uh, especially this occurs in malnourished patients, and this reaction is seen on the skin. So these are all inflammatory reaction like appearance on the skin, called as lepra reaction or sulfone syndrome or erythema nodosum leprosum. Okay, and this can be very much treated by corticosteroid like drugs. Our second drug is clofazimine. Now, clofazimine is a dye which is very complex in nature. It's having a structure, a very complex structure, which is a phenazine congener, and it is a rimino-phenazine dye, which is unique and having a complex structure. This drug has a very peculiar anti-inflammatory activity, and therefore it is very effective in patients who are facing lepra-like reactions with dapsone. So this is able to take care of the inflammatory side effects. The mechanism of action of this drug is that this drug is largely concentrated on the bacterial DNA. So it basically interferes with the bacterial nucleic acid metabolism, and therefore it involves the DNA of the bacteria. This drug, when it is given orally, it tends to accumulate in the body and gets sequestered in the, it gets concentrated in the phagocyte system. Um, this is how it also has a good effect with its mode of action. The plasma half-life of this drug is around 8 weeks, and the antileprotic effect is delayed and is usually not seen for 6 to 7 weeks because of the plasma half-life. Once the plasma half-life is longer, so naturally the effect will also be prolonged. However, dose-related effects like nausea, giddiness, or headache, gastrointestinal disturbances are generally observed. And with this drug, clofazimine, this being a dye, red dye, even the skin and the urine can develop reddish color. And lesions are blue-black, are with blue-black discoloration. Okay, so this is a very peculiar effect with clofazimine. Now, clofazimine is a drug which is combined with dapsone normally. There is one more drug called rifampicin, which we have seen in anti-tubercular therapy. That drug is also used along with dapsone, and since dapsone develops bacterial resistance very easily, this drug is being combined, that is rifampicin is combined with. So rifampicin is normally combined with dapsone, and this combination along with clofazimine is also sometimes followed. Um, there are other drugs also which are supportive drugs which are used in the treatment, like for example thiocetazone. Now this drug is having tuberculostatic activity, and it was found to be effective more on tuberculoid type of leprosy than the lepromatous forms of leprosy. But this bacterium, Mycobacterium leprae, develops resistance as the treatment is continued, and also develops cross resistance to another sister drug under this class called as thiambrutocin. And moreover, thiacetazone is more toxic than thiambrutocin, but is much cheaper and may be useful as a second line drug used in the treatment of leprosy. So other drugs like your corticosteroids or aspirin type of drugs are basically used as supportive drugs. They are cheaper drugs, and they are basically used to take care of the underlying the inflammation which arises due to the use of dapsone and all. So basically used as anti-inflammatory drugs and are basically employed for their symptomatic relief. Now, talking about the WHO regimens in the treatment of leprosy, the World Health Organization has come up with two regimens depending upon the two main types of leprosy, that is the multibacillary leprosy, which is also called as the lepromatous leprosy, or possibacillary leprosy, which is also called as the tuberculoid form of leprosy. So, in case of multibacillary leprosy, a 3-drug regimen is specified, and the treatment has to be strictly followed for at least 2 years or till the smear becomes negative. So, here you have dapsone, which is taken as 100 milligrams daily, rifampicin 600 milligram once in a month under supervision. Similarly, clofazimine also 300 milligram once monthly supervised under supervision, or 50 milligrams daily self-administered. Whereas possibacillary leprosy treatment should be given for at least 6 months. It's a 2-drug regimen, wherein dapsone 100 milligram daily self-administered, rifampicin 600 milligram once monthly supervised. So in both the cases, you have seen that dapsone, although it's one of the primary drug, the main drug used in the treatment of leprosy, it is never given alone because of the development of bacterial resistance, and it is combined with other drugs like rifampicin or with clofazimine. Okay, talking about the prophylaxis, dapsone seems to provide some moderate value, and this is the only drug which is proved to be prophylactic in case of high risk contracting patients. Okay, so with this we have completed with anti-leprotic drugs as well. Uh, Thank you.